my great pleasure and honor to introduce Professor Dr. Lionel Rostaing, consultant in clinical transplantation, Toulouse University Hospital, Toulouse, France. Professor Rostaing received his MD and graduation in nephrology at Toulouse University Medical School in year 1988. In 1989, he was graduated in immunology in Aix-Marseille University Medical School. In 1988, he received a fellowship in transplantation from Heidelberg in Germany. In 1989, he received another fellowship in transplantation from Bristol in the United Kingdom. In the period between 1990 to 1994, he worked as assistant physician in clinical hematology and assistant physician in nephrology, dialysis, and transplantation. In the period between 1994 to 1998, he worked as consultant in multi-organ transplant service, and in 1999, he offered the professorship of nephrology, and in year 2000, he received the PhD from Toulouse University. The main field of clinical and basic research include viral infections in dialysis and organ transplant recipients, anemia after kidney and liver transplantation, and the pharmacodynamic effects of immunosuppressants. Professor Rostaing is a member of numerous scientific organizations and authored and co-authored 40 articles and published more than 200 papers. Professor Rostaing will give us a part lecture about the French donation and transplantation model. Professor Rostaing, welcome to Mansoura Urology and Nephrology Center.
Means that locally we can't handle with the organs as we would like. So we can be a donor in France. So we've got two sets of donors, we've got the deceased donors and the living donors. So with regards to the deceased donors, so we mainly have brain dead donors. So roughly we have about 1,500 brain dead donors per year in France. So this number is very stable. It's stable because we have very few trauma on the road, but we have a lot of cerebrovascular accidents in all patients, and so therefore the quality of the organ is not that good for patients on the suitable donation. We also have donors after cardiac death. Means that when a patient has myocardial infarction and when it's not resuscitated, well, we can retrieve the organs, it's permitted. And now we've got the must-kill-free criteria donors. Means that when for a patient there is no medical hope, and when the physicians will suddenly decide to stop all the treatments, that is to say, the patient will die within a few minutes or hours or days. In these conditions, we can now retrieve the organs, as is the case already in the UK or Germany or Netherlands. And finally, for deceased donation, this is the Christian consent. That is to say, we've got a national registry of refusal, and so if I decide to refuse to donate after my death, I have to register to this national registry, but very few people do register actually. So it means that even the law is with us. We always ask to the family members whether they agree or not that their beloved donates. So it means that overall we've got a refusal rate of about 36%. So it's quite big. And so by law we are forced to collect family's opinion, even though the law states that it's not necessary. So it's great. What about living donors? So in France, living donation is restricted to kidney donation. It was before that it was possible to donate a liver, half of a liver, or half of the lung for kidney, for lung transplantation. But nowadays it's not permitted, so it's only restricted to kidney donation. The law is very liberal. It means that any friend, provided that you can demonstrate that your friendship is longer than 2 years, so any friend can donate. So first of all, we make a medical workup, and this is done by the transplant nephrologist, and we perform normally mycelium clearance, but this could be a different state of mycelium clearance. And then thereafter, after this medical workup, the surgeon will decide whether it's possible or not with regards to the number of arteries, for example. And he will decide whether it will be laparoscopic or robotic surgery. And robotic surgery in my center is dedicated for obese donors, for obese recipients, and for female patients. And so afterwards, when all the medical and surgical work have been done, potential donor is audited by an ethical committee, and this is mandatory even though the donor is a husband or wife or mother, and so forth. And so this ethical committee can say no. And so this ethical committee convenes every month, and so they audit roughly around 6 potential donors. It means the donors have to queue up. So it takes time. The process of living donation in France takes time, at least 4 months. And afterwards, after this ethical committee has been passed, so if the answer is yes, the last word is given by the judge, and so by law, every potential donor has to show up before the judge, and the judge can say no. Normally it says yes. And so when it's done, you can proceed to donation. Okay, and in France, by law, also all the workup, the donation, the hospital stays are fully covered by law, by the hospital. And so it's very important because if you are living in France, or if your donor is living in the US, or if your donor is living in Egypt, they can come to France, they can donate, and all their expenses are covered by our hospital. And so it's great. So How many transplant centers do we have in France for kidney transplant centers? So in France we perform 3,000 kidneys a year, 3,000. So there are 34 kidney transplant centers, and of these there are 3 pediatric centers, 2 in Paris and 1 in Toulouse. And no, 1 in Paris, 1 in Toulouse, and 1 in Lyon. There are 22 liver transplant centers, and of these there are only 2 pediatric centers. There are 16 heart centers, 12 lung centers, 9 pancreas centers. In my hospital, we perform any kind of transplantations. And by law, all of these transplant centers are public centers, and by law, all are affiliated to University Hospital. If you are not affiliated to University Hospital, you can't open a transplant center even though you are okay, so if you come back to the donors, for the deceased donors, there are more than 200 hospitals that are authorized to identify and to manage such donors. It's very important because, as I showed you, there are only 34 kidney transplant centers, but more than 200 hospitals, such as the local, secondary, tertiary hospitals, are authorized. I mean, they have to apply, to identify and manage such donors. Thereafter, when the donor is identified, they are either managed locally or they are transferred to a university hospital. And for living kidney donors, by definition, by law, only the university kidney transplant centers can look after living kidney donors. Okay, and at the moment, with regards to living donation, 80% is performed by laparoscopic surgery and 20% by robotic surgery. As you know, robotic surgery is very costly, so that's the issue. So how is working the kidney allocation system with regards to deceased donors? Honestly, for the living donors, you can do whatever you want. But for the deceased donors, it's complicated. So till now, that will change next year. Till now, 1 kidney is transplanted locally. It means that if yesterday there was a deceased donor in Toulouse University Hospital, we can keep locally 1 kidney, but that kidney is allocated to one of my patients by the national database, so I can't choose my recipient. It means that the potential recipients are decided by the computer system, okay? And so I have to take the first one, and if I decline, I have to justify, otherwise I would be in trouble. And the allocation system is based on info. The local allocation system is based on age matching, time of waiting list, and age matching. So, 1 kidney is kept locally, but next year it will be changing, it will be no kidney locally. So. And 1 kidney is for the whole community, that is to say, by definition, 1 kidney is shipped. So, first, the computer system will look after kidney pancreas recipients, because we perform not enough kidney pancreas transplants in France. You know, we need very good donors, younger than 45, with a BMI lower than 25, something like that. So a lot of issues, but it's very difficult to have very good kidney pancreas donors. So computer system will look after the kidney pancreas recipient. If there is no such recipient in France, the computer will go to highly sensitized recipients, because these patients are very complicated to